Dear candidate, classifications, definitions and brief short notes in these audio cassettes should give you an insight to formulate an intelligent answer to the questions asked in the orthopedic specialty examination. Audio cassettes are aimed to revise the classifications and remember them by repeated listening while on the move. Revision handbook provided with it is a helpful aid for quick reference. Let's begin with section 1 on basic sciences. What do we know about the bone? Normal bone is lamella bone, which can either be cortical or cancellous. Immature or pathologic bone is oven bone. Cortical bone forms about 80% of the skeleton and is composed of tightly packed osteons or Haversian system. It has a relatively high Young's modulus. Cancellous bone is spongy, trabecular, less dense, but undergoes more remodeling. Bone cells are osteoblasts, osteocytes, bone lining cells, osteoclasts, and osteoprogenitor cells. Osteoblasts originate from mesenchymal progenitor cells. Osteocytes originate from osteoblasts. Macrophages and osteoclasts share a common origin. Osteoblasts produce type 1 collagen. Wet weight composition of the bone, 70% of it is made up of mineralized matrix, 25% organic matrix with cells, and 5% water. Dry weight composition of the bone, 40% is organic component and 60% of dry weight is made up of inorganic mineral component. Let's look into the organic component first. 90% of this organic matrix is made up of collagen and rest of the organic matrix is made up of proteoglycans, non-collagenous matrix proteins, growth factors, and cytokines. Collagen is a triple helix of tropocollagen. Hole zones and pores exist within the collagen fibrils for mineral deposition. Glycoproteins, phospholipids, phosphoproteins, osteonectin, osteocalcin, osteopontin are some of the matrix proteins. They promote mineralization and bone formation. Growth factors and cytokines include transforming growth factor beta, insulin-like growth factor, interleukins, and bone morphogenic proteins, BMP 1 to 6. These play a role in bone cell differentiation, activation, growth, and turnover of the bone. Proteoglycans are non-collagenous proteins in the bone matrix. They are dermatan sulfate, heparan sulfate, keratin sulfate, and chondroitin sulfate. Chondroitin sulfate is most abundant of the 4 proteoglycans. Function of the proteoglycans is not well understood. What about 60% dry weight inorganic mineral component of the bone? This consists mainly of calcium hydroxyapatite. Formula is Ca10PO4 6OH. Calcium hydroxyapatite is responsible for compressive strength of the bone, whereas collagen is responsible for the tensile strength of the bone. Osteocalcium phosphate is also part of this inorganic matrix. What do we know about bone remodeling? Wolff's law states that bones remodel according to stress applied to it. More the stress, better the bone formation. Piezoelectric charges also influence the bone remodeling. Compression side is electronegative, tension side is electropositive. Cortical bone remodels by osteoclastic tunneling, also called cutting cones. Cancellous bone remodels by osteoclastic reabsorption, followed by laying down of new bone by osteoblasts. Let's now discuss bone metabolism. 3 most important influences on bone metabolism are parathyroid hormone, vitamin D and its metabolism, and calcitonin. The factors which have beneficial effect on bone formation are: number 1, sex hormone; 2, transforming growth factor beta; 3, insulin-like growth factor; 4, colony stimulating factor; 5, interleukin 1, interleukin 6; 6, bone morphogenetic protein. More than 7 BMPs are recognized. BMPs belong to TGF-beta superfamily. Factors having inhibitory effect on bone formation are: number 1, thyroid hormones; 2, glucocorticoid hormones; 3, tumor necrosis factor alpha; 4, prostaglandin F2 and E2; and 5, leukotrienes. bone circulation, mainly three systems are described. Number 1, nutrient artery with high pressure system. 2, metaphyseal epiphyseal system. And 3, periosteal vascular system, which is low pressure system. What about mechanical properties of the bone? Bone strength is derived from its composite nature of the material. Tensile property of the collagen, compressile strength of minerals, and the nature of bone structure consisting of Haversian, circumferential, and interstitial lamellae work synergistically to avoid yield or ultimate strain on the bone. Yield strain of the bone is approximately 7,000 microstrains. Ultimate strain of a normal bone is approximately 15,000 microstrains. What do we need to know about growth plate of the bone, otherwise called physis? There are two types of growth plates. Horizontal growth plate that allows growth of the epiphysis towards the metaphysis. Spherical growth plate that allows growth of the epiphysis towards the joint. Zones of the horizontal growth plate are: number 1, reserve zone; 2, proliferative zone; 3, hypertrophic zone, which is subclassified into zone of maturation, zone of degeneration, and zone of provisional calcification. Proliferative zone is kinetically active zone of the growth plate. In the lower hypertrophic zone, otherwise called provisional calcification zone, calcium is packed in vesicles and deposited into the surrounding matrix. Entire growth plate synthesizes type 2 collagen. Only lower hypertrophic zone synthesizes type 10 collagen. Type 1 collagen appears in the metaphysis. Hütter-Oakman's law of growth plate states that increased pressure causes decreased growth and decreased pressure causes increased growth. This is evident in the pathologic state like Blount's disease. Hütter-Oakman's law is opposite to that of Wolff's law of bone remodeling. Rickets and osteomalasia tends to have abnormal provisional calcification zone because of inappropriate calcification. Mucopolysaccharidosis affects the maturation and degenerative part of the hypertrophic zone. Achondroplasia affects proliferative zone. Pseudoachondroplasia affects reserve zone. Osteoporosis, osteogenesis imperfecta, scurvy, and metaphyseal dysplasia affect the secondary spongiosa zone of the metaphysis. Let's talk about the joint. Joint development is divided into three phases. Phase 1 is blastemal condensation of skeletal elements. Phase 2 is joint cavitation. Phase 3 is synovium and intra-articular structural development. Articular cartilage is a shock-absorbing structure. Nutrients and metabolic mediators are provided via the synovial fluid, which help to maintain the metabolic state of the cartilage. pH of the articular cartilage is 7.4. 65 to 80% of wet weight of this cartilage is water. Collagen forms 10 to 20% of the wet weight, or more than 50% of dry weight. 90 to 95% collagen in the articular cartilage is type 2 collagen. Collagen gives tensile strength to the cartilage, and type 10 collagen is associated with calcification of cartilage. Proteoglycans form 10 to 15% of the wet weight of the articular cartilage. This gives compressive strength to the cartilage. Proteoglycans also play an important role of inhibiting calcification. Chondrocytes form 5% of the wet weight of the cartilage. Layers of the articular cartilage are: number 1, superficial layer forms 10 to 20% of the lot. Number 2, middle layer forms 40 to 60%. Number 3, deep layer forms 30%. Number 4, tide mark. Number 5, last layer, which is close to the ossific nucleus, called calcified cartilage. These 5 layers of cartilage are also named as: number 1, gliding zone; 2, transitional zone; 3, radial zone; 4, tide mark; and 5, calcified zone. Early events in osteoarthritis are characterized by a possibly reversible loss of proteoglycans and an activation of repair mechanism in the chondrocytes. Chondroitin keratin sulfate ratio is reversed in osteoarthritis. Late events include the modulation of extracellular matrix, into a variant with inferior biomechanical properties. Damaged cartilage fails to repair to its normal zonal organization, and the collagen regenerated is usually unsuitable for repetitive load bearing. Synovial fluid is produced by the type B fibroblast-like cells of the synovium. Synovial fluid is made up of proteinase, collagenase, hyaluronic acid, and prostaglandins. Main functions of the synovial fluid are nourishment of the cartilage and lubrication. Main mechanism of lubrication in the joint is hydrodynamic lubrication and boundary lubrication. Hydrodynamic lubrication is where fluid separates the surfaces under load, and boundary lubrication takes place on the slippery surfaces. Other types of lubrications are weeping lubrication and boosted lubrication. Failed attempt of chondrocytes to repair damaged cartilage is osteoarthritis. Osteoarthritis is characterized by increased water content, alterations in the proteoglycans ratio, collagen abnormalities, and binding of proteoglycans to hyaluronic acid. Two types of osteoarthritis are recognized: primary and secondary. X-ray features are osteophytes, subchondral cysts, and joint space narrowing. Knee is the most commonly affected joint. What are the common causes of charchot joint? They are: number 1, tabes dorsalis; 2, syphilis; 3, diabetes; 4, syringomyelia; 5, meningocele; 6, congenital insensitivity to pain; 7, other neurologic problems. What are the Jones criteria for the diagnosis of acute rheumatic fever? 5 major and 5 minor criteria are described. 2 major criteria or 1 major and 2 minor criteria are necessary to diagnose rheumatic fever. 5 major criteria are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. 5 minor criteria are fever, arthralgia, previous rheumatic fever, elevated ESR, prolonged PR interval on ECG. Felty's syndrome is rheumatoid arthritis with splenomegaly and leukopenia. Still's disease is acute onset rheumatoid arthritis with fever, rash, splenomegaly. A few words on rheumatoid arthritis. Rheumatoid arthritis most commonly affects hands. Etiology is not well understood, may be related to a cell-mediated immune response. HLA focus of rheumatoid arthritis are at HLA DR4 and DW4. Subcutaneous nodules are seen in 20% of rheumatoid arthritis. Synovium and soft tissues are primarily affected before joint surface involvement in rheumatoid arthritis. Elevated ESR, C-reactive protein, and positive rheumatoid factor can be seen in 80% of the cases. Treatment of rheumatoid arthritis is focused on: number 1, symptoms; 2, synovitis; 3, joint destruction; and 4, deformities. Cervical spine evaluation is essential in all severely affected rheumatoids. Radiological features in rheumatoid arthritis are periarticular erosions and osteopenia. Protrusio estabili is often a finding in these patients. Systemic lupus erythromatosis presents with fever, butterfly malar rash, pancytopenia, pancarditis, nephritis, and polyarthritis. Joint destruction is not as destructive as rheumatoid arthritis in systemic lupus erythematosus. What about juvenile rheumatoid arthritis? 3 categories are described in this condition. Number 1, systemic juvenile rheumatoid about 20%. Number 2, polyarticular juvenile rheumatoid about 50%. And number 3, posteoarticular juvenile rheumatoid about 30% of all the cases involved. Juvenile rheumatoid arthritis is called polyarticular when 5 or more joints are involved, and it is posteoarticular if 4 or less joints are affected with this condition. Depending on rheumatoid factor detected in the serum, polyarticular juvenile rheumatoid arthritis can be either seronegative or seropositive. Posteoarticular can be either early onset or late onset disorder depending on the age of the onset. Early onset posteoarticular rheumatoid arthritis usually associated with iridocyclitis. Late onset posteoarticular rheumatoid arthritis is the only type of rheumatoid which is seen more common in boys. Spondyloarthropathies. Spondyloarthropathies are characteristically have positive HLA-B27 and negative rheumatoid factor. Main conditions under this heading are 1. Ankylosing spondylosis, 2. Reiter's syndrome, 3. Psoriatic arthropathy, and 4. Enteropathic arthritis. Crystal deposition disease. Main conditions under this label are gout, chondrocalcinosis, and calcium hydroxyapatite crystal deposition disease. If you are suspecting infection in the joint, aspiration and joint fluid analysis is most helpful procedure. In pyogenic infection, fluid will be turbid with low glucose levels, and microscopy will show more than 80,000 WBCs with more than 75% polymorphonucleosides. Gram stain aids in the diagnosis of infection. There are 13 types of collagens in the human body described. These are type 1 to type 13. Type 1 collagen is present in bone, tendon, meniscus, annulus of the intervertebral disc, and the skin. Type 2 collagen is found in the articular cartilage and nucleus pulposus of the disc. Type 3 is in skin and blood vessels. Type 4 in the basement membrane. Type 5 and 6 are found in small amounts in the articular cartilage. Type 7 and 8 are found in the basement membrane. Type 9 is found in small amounts in the cartilage. Type 10 is the collagen present in the abnormal cartilage associated with calcification. Type 11 is present in small amounts in the articular cartilage. Type 12 is found in the tendon. Type 13 collagen is found in the endothelial cells. Most important ones to remember are type 1 collagen, which is present in bone, tendon, meniscus, annulus of intervertebral disc, and the skin. Type 2 collagen, which is found in the articular cartilage and nucleus pulposus of the disc. Skeletal muscle is made up of sarcomeres. Sarcomere consists of thick and thin filaments in an intricate arrangement that allows fibers to slide on each other. Thick filament of the sarcomere is myosin and thin filament is troponin and tropomyosin. H zone has thick filaments. I band solely consists of thin actin filament. Types of muscle contractions are: number 1, isotonic contraction, which exhibits constant tension in the muscle, which can be concentric or eccentric. Concentric isotonic contraction is when muscle shortens during contraction, and eccentric isotonic contraction is when muscle increases in its length during contraction. Number 2, isometric contraction. It is when the length of the muscle remains same with contraction of the muscle. Type of muscle fibers are: number 1, slow twitch or type 1 fibers, which take place in endurance activities or otherwise called aerobic activities. Fast twitch or type 2 fibers take part in anaerobic activities, particularly in sprinters. Let's look into the nerve injuries. Two most popular classifications of nerve injury are Seddon and Sunderland. Seddon's classification is neuropraxia, axonotmesis, and neurotmesis. Sunderland has classified the nerve injuries into 5 groups. Number 1, neuropraxia. Number 2, axon injury with intact endoneurium. Number 3, axon injury with intact perineurium. Number 4, axon injury with intact epineurium. And number 5, complete nerve disruption or neurotmesis. 3 different mechanisms play a role in the recovery of nerve injury. Number 1, remyelination through areas of focal neuropraxia. Number 2, collateral sprouting from surviving axon motor terminals to the denervated muscle. Number 3, nerve regeneration from the site of injury. Diagnostic electrophysiologic procedures used are either nerve conduction studies or needle electromyography. Nerve conduction studies are either motor nerve conduction studies or sensory nerve conduction studies. Motor nerve conduction studies look into conduction velocity, distal motor latency, and amplitudes. Sensory nerve conduction studies look into sensory nerve action potential, amplitude, and conduction velocity. Needle electromyography is done in two phases: muscle at rest and muscle during action. Normal muscle at rest is electrically silent. Some of the metabolic and endocrine syndromes affecting bone are described below in brief. Primary hyperparathyroidism, incidence 1 in 1,000 subjects. Calcium and parathormone both are elevated with hypercalcemia. Most common cause is adenoma, 80%. Parathormone increases calcium resorption from the bone, calcium absorption from the intestine, and calcium excretion from the renal system. X-ray findings are osteitis fibrosa cystica, osteopenia, localized bone resorption at the terminal phalanx or distal clavicle, and changes in the skull. Subcortical bone resorption in the jaw are called brown tumors. Hypoparathyroidism is an absolute or relative deficiency or inadequacy of parathyroid function. If associated with parathyroid hormone resistance, it is called pseudo-hypoparathyroidism, otherwise called Albright's hereditary osteodystrophy. Shortening of the metacarpals and metatarsals, particularly the fourth metacarpal, brachydactyly, and exostosis are some of the features of pseudo-hypoparathyroidism. Renal osteodystrophy is a complex bone disorder in patients with chronic renal failure, which ends with inability to excrete phosphate and compensatory reduction in serum calcium. What are the types of rickets? Number 1, vitamin D deficiency rickets. Number 2, hereditary vitamin D dependent rickets. And number 3, familial hypophosphatemic rickets, otherwise called vitamin D resistant rickets. Serum alkaline phosphatase is raised in all three groups of rickets. Clinical features are as follows. Vitamin D deficiency rickets, we may find Harrison's groove of the sternum or rachitic rosary, which is enlargement of costochondral junction. X-ray findings include enlarged physis and cupped metaphysis. Treatment is 5,000 units of vitamin D. Vitamin D dependent rickets is the defect in renal 1-alpha hydroxylation of 25-dihydroxy vitamin D3. Treatment here is very high doses of vitamin D, up to 20,000 to 100,000 units of vitamin D daily. Vitamin D resistant rickets is X-linked recessive disorder and also called hypophosphatemic rickets. Decreased phosphate level in the blood and increased alkaline phosphatase is a feature here. Combination of phosphate with vitamin D is the treatment of choice in this condition. Hypophosphatasia is an autosomal recessive condition where there is low alkaline phosphatase in the blood with typical features of rickets, but alkaline phosphatase is low. No satisfactory treatment for this condition is yet available. Osteomalasia is an adult counterpart of rickets. Etiology of osteomalasia can be dietary, renal tubular acidosis, or tumor-induced osteomalasia. Serum calcium may be low and alkaline phosphatase is almost always high. Bone biopsy shows increased width of unmineralized bone. X-ray may show Looser's zone or pseudo-fractures on the concave surface of the long bones as well as on flat bones. Osteomalasia is due to lack of calcium, so compression side is weaker than the tension side. This is why pseudo-fractures in osteomalasia are often on the concave side. In osteogenesis imperfecta, the tensile side is weak because of abnormal collagen, so Looser's zone is usually on the convex side. Scurvy or vitamin C deficiency can lead to abnormal collagen in the bone, resulting in bone pains and deformities. X-ray findings of metaphyseal clefts are characteristic of scurvy. Osteoporosis. Osteoporosis is diminution of bone mass. Mainly two types are described: primary osteoporosis or secondary osteoporosis. Primary osteoporosis can be either type 1 or type 2. Type 1 has excessive loss of cancellous bone, which primarily occurs at the time of menopause. Type 2 has excessive loss of cancellous as well as cortical bone, which primarily takes place 15 to 20 years after menopause and in elderly men. Type 2 osteoporosis is because of senile bone mass diminution or senile osteoporosis. This is also called low turnover osteoporosis. Type 1 has got more predilection for cancellous bone fractures like wrist fractures, whereas type 2 tend to have cortical as well as cancellous bone loss, resulting in intertrochanteric femur fractures. Secondary osteoporosis is due to underlying bone conditions like hyperparathyroidism, hyperthyroidism, and number of other conditions which increase the rate of bone remodeling as well as the rate of bone loss. This is also called high turnover osteoporosis. Commonly used techniques to measure bone density are DEXA scan, dual energy X-ray absorptiometry, or quantitative CT. How would you evaluate vertebral fractures in an osteoporotic patient? Mnemonic TOMIO is helpful. T for tumor screening, O for osteopenia screening, M for marrow screening, E for endocrine screening, O for osteomalasia screening. Number 1. Tumor screening consists of X-ray, bone scan, MRI, and CT scan. Number 2. Osteopenia screening is DEXA scan. Number 3. Marrow screening is full blood count, serum electrophoresis for myeloma. Number 4. Endocrine screening for parathyroid, cortisol, thyroid function, and diabetes. Number 5. Osteomalasia screening for rickets before making diagnosis of osteoporosis. So, TOMIO for osteoporosis in vertebral fractures. And please remember, primary osteoporosis is diagnosis of exclusion. Treatment of osteoporosis. Number 1. Decrease bone loss by phosphate or diphosphonate. Number 2. Halt the bone loss by calcium, vitamin D, calcitonin, estrogen, and mild exercises. Number 3. Increase the bone mass by using fluoride with calcium, fluoride with vitamin D, fluoride with estrogen, fluoride with calcitonin, and extensive exercises. Preventive therapy is given to women at risk by recommending increased physical activity and estrogen in early postmenopausal years. Estrogen in early postmenopausal years is currently highly recommended in those who do not have the risk of this treatment. Progestin probably diminishes the risk of endometrial cancer. Let's talk about Paget's disease of bone. 3 to 4% of population over age of 40 years suffer from Paget's disease. Pathologically classified as lytic and sclerotic phases, eventually end up as a mixed phase. Paramyxovirus antibodies have been identified in Paget's disease, suggestive of chronic viral infection. Clinical manifestations and complications of Paget's disease can be remembered with the mnemonic ABCD PM square. A for arthritis, B for blood flow problems, C for cranial nerves, D for deformity, first P for pain, second P for pseudoarthrosis, first M for metabolic complications, and second M for malignant transformation. Arthritis in Paget's can be due to 1. Articular bone deformation, 2. Abnormal joint biomechanics, 3. Subcapital support loss, or 4. Gout. Blood flow complications are due to hyperdynamic circulation. Cranial nerve palsies are common with Paget's disease and mainly affect hearing. Deformities are due to the abnormal bone structure and bowing of long bones. Pain is associated with active disease. Pseudoarthrosis may result in a fracture with delayed or non-union. Metabolic complications are hypercalciuria and hypercalcemia and are common after immobilization for any reason. Malignant bone tumor is very rare, about 1% incidence is reported. X-rays in Paget's disease will show mixed picture of osteolysis and osteosclerosis. Enlargement of the vertebral body is a hallmark of Paget's disease of the spine. Treatment is again addressed to these ABCD-PM square. Treatment of arthritis, treatment for increased blood flow, hyperdynamic circulation during operation, treatment for cranial nerve palsy, treatment for deformities, treatment for pain, treatment for pseudoarthrosis and non-unions, treatment for metabolic disorders like hypercalcemia during the operation and after the operation, and lastly, treatment for malignant transformation of the bone. Medical management, calcitonin therapy and biphosphonates. Biphosphonates are first generation, second generation or new generation drugs. Etidronate is first generation, palmidronate is second generation, and alendronate is third generation biphosphonate. Total hip arthroplasties pose special problems in Paget's disease. Number 1, technical difficulties. Number 2, medical management to avoid hypercalcemia, acidosis and bleeding. Calcitonins and biphosphonates are commonly used but not proven. Number 3, heterotopic ossification is as high as 5%. Number 4, early prosthetic loosening is described but not been statistically proved. What do we need to know about Gaucher's disease? Most common lysosomal storage disease resulting from an inborn error of glycosphingolipid metabolism. It is an autosomal recessive condition. Hematological problems associated with Gaucher's disease are anemia, thrombocytopenia, and hepatosplenomegaly. Pathogenesis is incompletely understood. Progressive marrow infiltration leading to loss of trabecular bone and lytic lesions can lead to bone crisis. Gaucher's cells are not directly involved in bone resorption, but they cause intramedullary expansion and intraosseous increased pressure, resulting in extravascular compression and ischemia. Orthopedic problems in Gaucher's disease are: number 1, osteonecrosis or avascular necrosis of femur or humeral head, and number 2, vertebral compression fractures. Radiological changes in Gaucher's have been staged into stage 1 osteopenia, stage 2 medullary expansion, stage 3 localized destruction or osteolysis giving ground glass appearance, stage 4 osteonecrosis, and stage 5 diffuse destruction, epiphyseal collapse, and osteoarthritis. 2 complications to remember: AVN and bone crisis. Treatment consists of enzyme replacement therapy, particularly when treatment is initiated early in the disease. Treatment of complications are: number 1, bone crisis, supportive management; number 2, osteonecrosis, core decompression during the early acute phase; number 3, degenerative joint disease may need joint replacement; number 4, pathologic fractures may need internal fixation; number 5, neurologic compression syndrome may need spinal decompression. Biomechanics and biomaterials. Kinematics is the study of motion in relation to displacement, velocity, and acceleration without reference to the cause of motion. Kinesiology is the study of human movement and motion. Kinetics relates to the action of forces. Newton's laws are: first law is law of inertia. If a zero net external force acts on a body, the body will remain at rest or move uniformly. Second law is the law of acceleration. The acceleration A of an object of mass m is directly proportional to the force applied to the object. F is equal to m multiplied by A. Third law is the law of reaction. For every action, there is equal and opposite reaction. Vector has 4 characteristics: magnitude, direction, point of application, and line of action. Rotational effect of a force on a body about a fulcrum is movement. Work is force multiplied by distance. Energy is the ability to perform work which can be potential energy, otherwise called stored energy, or kinetic energy, which is energy due to motion. So energy can be potential energy or kinetic energy. Let's now look into biomaterials. Forces acting on a body is load. Deformation can be elastic deformation, or otherwise called temporary deformation, or plastic deformation, or otherwise called permanent deformation. P for P, plastic for permanent. Stress is equal to force divided by area. Stress is the intensity of internal force which can be compressive or tensile. Strain is the relative measure of deformation. Stress is proportional to strain up to a limit, otherwise called proportional limit. This is Hooke's law. Young's modulus is a measure of stiffness of a material or its ability to resist deformation. It's represented with the letter E. E is stress divided by strain. What do we look for in the stress-strain curve? Number 1, yield point. Yield point is the point where the material from its elastic region of temporary deformation goes on to plastic region, which is a permanent deformation. Number 2, ultimate strength is the maximum strength obtained by the material. And third thing to look for in the stress-strain curve is breaking point, which is when material fails. Plastic deformation is calculated by the change in the length after the load is removed. Material can be, number 1, brittle material which has minimal or no plastic deformation before it breaks. For example, polymethyl methacrylic cement. Number 2, ductile material which has large amount of plastic deformation before it fails, like metal which bends permanently before breaking. Number 3, viscoelastic material exhibits stress-strain behavior which is time and rate dependent. Example is bone. Fatigue failure is a property of metal. Fatigue failure occurs with repetitive loading cycles at stress below the ultimate tensile strength. If a stress is less than a predetermined amount of stress, called endurance limit, material may be loaded cyclically infinite number of times without breaking. Creep is progressive deformation of metal over an extended period. Corrosion is dissolving of metal. Corrosion can be, number 1, galvanic corrosion which is due to dissimilar metal. Number 2, crevice corrosion due to low oxygen tension. Number 3, stress corrosion due to high stress gradients. Number 4, fretting corrosion which is due to small movements abrading the outside layer. And number 5, miscellaneous corrosion due to intragranular inclusions. The following is the order of material with decreasing level of Young's modulus. Number 1, ceramic. 2, cobalt chrome. 3, stainless steel. 4, titanium. 5, cortical bone. 6, matrix polymer. 7, PMMA. 8, cancellous bone. 9, polyethylene. 10, tendon or ligament. 11, cartilage. Force is a vector quantity with magnitude and direction which will accelerate the body in the direction of application. Types of forces in the joint are: 1, external force, which is ground reaction force, gravitational force, and applied force through contact. Number 2, internal force, which is muscle contraction force. Joint contact, shear forces, and capsulo-ligamentous contractions are also part of internal force. Joint movements are gliding motion, spinning motion, and rocking motion. Ceramics are non-metallic materials that can be either bioactive or inorganic. Bioactive ceramics are glasses such as silicon dioxide and calcium phosphate ceramics. Calcium phosphate ceramics are hydroxyapatite, tricalcium phosphate, and fluorapatite. Inorganic oxide ceramics are alumina and zirconia. Types of wear in the arthroplasties can be: 1, abrasive wear, 2, adhesive wear, and 3, third body wear. Imaging of the musculoskeletal system is our next topic. The mainstay of nuclear medicine is bone scan. Here, Intravenously administered technetium-99M methylene diphosphonate, known commonly as MDP, is incorporated into bone by adsorption onto hydroxyapatite. SPECT is single photon emission computed tomography, which is three-dimensional bone scan in simple words. Tracer uptake is reflection of osteoblastic activity, which has three phases. Number one, first phase, radionuclide angiogram, every 2 to 5 seconds for 30 to 60 seconds. Number two, static blood pool phase, which reflects soft tissue destruction or distribution of the material. And number three, skeletal phase, which is delayed phase when the radioactive material is taken up by the osteoblast. Major orthopedic areas of application are infection, trauma, AVN, and neoplasia. Acute osteomalacia has got sensitivity and specificity reported to be more than 90%. Specificity drops to 33% when underlying bone pathology is present with infection. Most authors believe the leukocyte imaging is superior to gallium imaging for cases of complicated osteomyelitis. Leukocyte imaging is not related to bone turnover of the tracer and is more specific for infection where neutrophils are in abundance. Weaknesses of leukocyte scans are: number one, specificity is low in non-bacterial infections where neutrophils are not the major responders. Number two, leukocyte imaging of the vertebral osteomyelitis has less accuracy, especially the cold spots. Number three, technically it is more difficult to perform. Number four, neutropenic patients may not be well labeled. Ultrasound is based on the transmission of sound waves through tissue and the time it takes for the waves to be reflected back to the transducing probe. What is the underlying principle of CT scan? Computed tomography uses a tightly collimated fan-like beam of X-rays to produce tomographic images. What about MRI scan? Magnetic resonance imaging. Nuclear spin is the underlying principle of magnetic resonance imaging. Only those nuclei with an odd number of protons or neutrons possess nuclear spin. Hydrogen nucleus is utilized in medical MRI because of its natural abundance in the human body. Magnetic field is created around the body to be imaged, and the radio frequency pulse is used to deflect the orientation of the protons. Two aspects to consider. Number one, time required to restore 63% of equilibrium population of the magnetic moment to be aligned to the external magnetic field after being deflected by 90-degree pulse is T1 relaxation time. Number two, time required for 63% of the signal to disappear irreversibly is called the T2 relaxation time. In simple words, all the hydrogen ions are directed to one external magnetic field, which is the first step. Second step is the deflection of these ions by radio frequency waves. Third step, calculating the time required for 63% of the signal to return to the externally aligned magnetic field, which is T1 relaxation. Fourth step is to calculate time required for 63% of the signal to disappear completely when the external magnetic field is taken away, which is T2 relaxation time. Water in inflamed tissues is bright on T2 images of the MR scan. Annulus pulposus, infection and inflammation of the soft tissues as well as bone infection is bright on T2 images. Fat is bright on T1 image. H2O for T2, 2 for 2 is easy to remember. MRI scan is a better imaging modality for the structures with more water content. Bone does not have a lot of water, so CT scan is better imaging modality compared to MRI scan for bones. A few words on statistics. What are the basic statistical hypotheses? Number one, null hypothesis, or HO, states that there is no difference between the groups. In other words, No association between the disease and the risk factor exists. Number 2, alternative hypothesis or H1 states that there is difference between the groups. In other words, some association between the disease and the risk factor exists. What are the statistical errors? Type 1 error is rejecting the null hypothesis by mistake. Alpha is the probability of making this error. Alpha 0.05 means 5% chance of making a type 1 error. Simplistic way to describe it is that type 1 error is convicting an innocent person. Type 2 error is to fail to reject the null hypothesis when in fact null hypothesis is false. Beta is the probability of making this error. Here type 2 error is like setting a guilt person free. 1 minus beta is the power of the study. More the number, higher the power. Number is power. Incidence is the number of new cases in a population at a given time. Prevalence is total number of cases at a given time. Sensitivity is the number of true positive cases detected. True positives divided by all the subjects with the disease is sensitivity. Specificity is the number of true negative cases not detected. True negatives divided by all without disease is specificity. Positive predictive value is number of true positives divided by the number who are tested positive. Negative predictive value is number of true negatives divided by the number who are tested negative. Easier way to remember is to note that predictive values are for evaluating the tests. What is p-value? P-value is the probability of the difference between the groups occurred by chance. For example, P 0.05 means 5% probability of the difference being a chance occurrence. T-test is applied to calculate the difference between the two means of parametric data. For example, blood pressure readings of mean values of two groups are parametric data and can be compared using T-test. Paired T-test is applied to compare two values of the same population with the two values of another population. For example, two blood pressure readings at different times of each person in group A compared with two blood pressure readings of each person in group B. If there are 3 or more than 3 variables of parametric data to compare, ANOVA test is used. Chi-square test compares 2 or more percentages or proportions of categorical outcomes. These are not mean values. Mann-Whitney U-test, rank tests are used to compare two non-parametric data like pain and other subjective values. Meta-analysis is carried out by pooling data from several studies, maybe literature search, to achieve a greater statistical power. Case control studies are observational studies, often retrospective, sample chosen based on presence of the disease like patients and absence of the disease like controls. Cohort study is also an observational study. Here, sample chosen is based on the presence or absence of risk factor. Subjects are followed over a period of time for the occurrence of disease. Clinical trials are experimental studies, difficult to conduct, compares therapeutic benefits of 2 or more treatments.